Dr. Vikram will be going to speak on aortic aneurysms management, role of surgeon and interventionist. Whom does the data support?
Just an overview of what aortic diseases we come across, the aneurysms involving thoracic aorta, abdominal aorta and thoracoabdominal aorta, and the aortic dissections, acute, chronic and type A and type B. First we'll talk about abdominal aortic aneurysms. So indications for abdominal aortic aneurysm treatment depends on the size, the symptoms, and whether there is any impending rupture or already ruptured. The cutoff point is 5 to 6 centimeters, and the risk of rupture from there it keeps on increasing. So the elective, the aneurysm, if electively repaired, the mortality is low, and over the years it has come down. But simultaneously, if it is ruptured, the mortality increases, and the incidence is slightly on higher side on Western countries, probably due to the more the life expectancy, and it affects around 4 to 7% of adult population. This is an algorithm where the treatment manage the protocol for the management of abdominal aortic aneurysm. So the patient has large aneurysm with unsuitable anatomy and is fit, open repair. If suitable or fit or unfit, then it's EVAR. And if patient has large aneurysm, unsuitable anatomy and unfit, then observation. So this is an open repair where the laparotomy is done and aneurysm is resected and replaced with a Dacron tube. This carries quite a bit extensive postoperative complications, and the approach is usually through retroperitoneum, and it can be approached through peritoneum as well, especially in case of ruptured aneurysm. So the abdominal aneurysm is the most of the research has been conducted on this aneurysm to develop the techniques of endovascular treatment, which reduces laparotomy, reduces the cardiac and septic complications, and is less invasive, which is reflected with rapid recovery of the patients. Dr. Parodi was the first person to implant the infrarenal aortic stent in Argentina, and subsequently the next time is the earliest device, and from there on the techniques and the device the components have tremendously improved, and this is one of the patients who has infrarenal abdominal aneurysm and which has been successfully stented. And this is one of the companies which makes the stent grafting. So coming on to the results, which I am going to talk whether the patient, the surgical approach is better or the endovascular. One of the surgeons from Boston, Brewster et al., he published two landmark studies. One, long-term durability of open abdominal aneurysm. He studied on 540 patients over 2 years, and mean age was 73, and these patients had the survival rates of 70% at 5 years and nearly 45% at 10 years. Same time, he had another study which the EVAR was assessed in 873 patients with mean follow-up 27 patients, and remarkably 30-day mortality was 1.8%. And there was nearly 16% of the patients who crossed over from the medical management patients into the EVAR, so-called the unfit patients were open, they crossed over into the EVAR technique. And most of the patients were, more than 30% were 80 years of age. But when they studied, the advantage of EVAR was seen only up to 2 years. After that, the curves, they separated. Like the freedom from reintervention and overall survival was much better with open repair compared to the EVAR. But these studies was done when the new stents were introduced into the market, and also the high-risk patients who are unfit for open had these procedures. So there's a difference of survival rates in these patients. Within the open aneurysm repair, when the age was adjusted, there was remarkable difference between patients with less than 75 years and more than 75 years. So the more than 75 years patients who are unfit, probably EVAR would be the ideal choice. These are two trials which are conducted, one in England, in London, Imperial College, other one is a Dutch study. Both of them, they had good survival rates with EVAR and open. They were comparable at 2 years. But the DREAM trial, after 2 years, there was a significant difference, and open was scoring much better than EVAR. So in London, they conducted another trial, EVAR-2 trial, on 338 patients, more than 60 years of age, group patients. This trial, they included only high-risk patients, and the 30-day mortality was 9%, and the 4-year survival was 34% compared to 38% in no intervention group. So they concluded it's not a safe procedure in such high-risk patients, and also the cost factor involved in the procedure and as well as the follow-up was exorbitant. So once the techniques were developed for abdominal aneurysm, the endovascular stenting, this was extended into the thoracic aortic diseases, the aneurysms and dissections. So this is a modified Crawford classification, and the type 5, the last one, is a Safi's modification from Houston. So these are 1 to 5. So we have two repair options, either open or endovascular. So historically, all patients had open surgeries, but of late, the endovascular surgery has been picking up in most of the centers, especially in patients who are unfit for open procedure. This is an open repair branch graft. One of the Koselli from Texas has one of the largest series. He has more than 2,000 patients of open repair of thoracoabdominal aneurysms. And if you look at the 30-day survival, is excellent across the various types of aneurysm, 1 through 4. And the paraplegia rates, in the beginning they were nearly 12%, but has come down to maximum of 6% in extent to aneurysms. And similar results were also reported by Hazem Safi from Texas, and Bavaria from Philadelphia, and Cameron from Dukes. He is Dr. Michael Dake. He was the first person to put in TVAR in thoracoabdominal and aortic aneurysms in 1994. So to perform TVAR or endovascular repair, we need to have a proper CT scan for planning, especially for landing zones, the proximal and distal landing zone. At least it should be around 2.5 to 3 centimeters, and the diameters of the landing zones. And the graft should conform the aortic arch, otherwise the graft can beak or intercept itself, and the delivery system has to go through the iliac vessels. So the diameter of the iliac vessels, whether they are diseased, they all should be clearly detailed in CT scan. These are the zones which are important in planning the stenting. The zone 0 is up to the innominate, zone 1, zone 2 and zone 3. So, and also the stent is oversized. Once we take the diameter of the aneurysm and the landing zone, at least 10 to 15% should be oversized. The stent should be oversized so that it abuts the aortic valve, so that it doesn't migrate. These are the beginning, the primitive designs of aortic stenting. And now the present day, we have got 3-4 companies which manufacture the aortic endographs. This is a hybrid theatre. This is one of the examples where there was two aneurysms. One was stented successfully. These are the three trials conducted by three major companies which produce endovascular stents, and all three trials have shown, which were compared to open, all the endovascular stenting versus open, they all showed 1 year mortality less compared to the open. But they haven't studied more than 1 year. This was only 1 year, and the ICU stay, hospital stay were all significantly less compared to open. On similar lines, Eurostar in UK, they also conducted series, and FDA phase 2 trial in US, they all showed initial 30-day mortality very low compared to open procedure. This was another study from Boston, which also shows significant difference in immediate post-operative mortality. But in 2010, a systematic review of all the of all the studies which are done, the non-RCTs. There was no RCT in these stenting versus open surgical repair of descending thoracic aortic aneurysms. So in all this in this meta-analysis, they showed the initial death, the death at 30 days, it was favoring TVAR, but the stroke and 1 year mortality, they all were not showing any favorable to the TVAR. The group was heterogeneous, but still it was not completely favoring TVAR. And death at 2 to 3 years, there was no difference between open and TVAR. So what they concluded was this TVAR is it's most suitable for patients who are unfit, who are elderly, and are presenting with the complications at the time of presentation. So then this TVAR was extended again into the aortic management of aortic dissection as well. The type A is always surgery, type B if uncomplicated medical management, but especially the TVAR started picking up in patients with type B dissection with complications like malperfusion or impending rupture. So in these patients, the primary goal was to cover the primary site, which in turn leads to lumen recovery, true lumen recovery and false lumen thrombosis. But some of the patients, they had a persistent patency. In those cases, you assess the malperfusion if there is any, and go on with another stenting to cover that area as well. Bavaria from Philadelphia, he studied 35 patients with complicated type B dissection. In his experience, the 30-day mortality was 2.8. At the same time, for a complicated type B dissection, the open repair the mortality was anywhere between 25 to 50%, with very high perioperative renal failure, stroke, paraplegia of 12 to 15%. But in his study, the spinal cord ischemia was 2.8%, and mean hospital stay was 16 days. But these results did not extrapolate with other studies, especially the IRAD, which maintains the registry of acute aortic dissection, where they said there was no difference in 3-year mortality in all patients with acute type B. Either you treat with medically, surgically, or endovascular. But the chronic type B dissection, they present a different challenge because of thick intimal flap and patent false and true lumen, and some of the vessels originating from the false lumen. So the Ninebar, he conducted an in-state trial where he isolated 597 chronic patients who presented with type B dissection. That's more than 2 weeks to 52 weeks. Patients with a type B dissection of these 597 patients, 140 patients were randomized, 72 to the EVAR and 68 with open. And what is what the results showed was there was the medical management, optimal medical management was better to TEVAR. So there was no advantage. This was the first randomized trial, and there was no difference in death rates. There was another study in European Journal recently in May. It's a systematic review in chronic type B dissection, even 567 patients. The midterm mortality was 9.2, but the absolute benefit was none. In circulation, another the US Medicare population was studied. Even here, the TEVAR did not show any great benefit at 5 years compared to open repair. So now, of late, most of these TEVAR and EVAR, they have been applied to aortic arch replacements, where the neck vessels are debranched in the first stage, and later on the arch being stented. Similar, the abdominal aneurysm involving the renal vessels or the mesenteric or celiac, both all being branched stenting or the fenestrated grafts. First one is a fenestrated, and the other one is the branch grafts. These they require the steep learning curve and excessive planning with an intervention radiologist, and also the custom-made stenting, the stents. These are all the custom-made stents. This is one of the patient who had branch stenting into celiac, SMA, and renals. Some of the patients, they present with complete aneurysm, starting from ascending or the root to proximal descending or thoracoabdominal. In those patients, there are options of two-stage with ascending total arch with elephant trunk, followed by open TA repair or TEVAR. And single stage is also possible, where a surgeon uses open evita prosthesis. This is one of the processes which has Dacron graft attached to a stent, and this is the delivery system. And this was taken in Liverpool. Actually, they were replacing the ascending arch and stenting the proximal descending. But with this stent, with the evita, you can only stent up to the level of sixth rib or the level of pulmonary veins, not below that. So this is a stent which is being introduced through the arch into the descending, and then you press this to release the stent. So other conditions where TEVAR has role is intramural hematoma of descending thoracic or penetrating ulcers, and also in traumatic aortic transection. But little is known, the long-term results, especially in young patients who have traumatic aortic resection, the durability and of the endovascular stent is a question. So all in all, the endovascular repair definitely has immediate benefits of reducing early morbidity and mortality. But the long-term success of these endografts needs to be assessed. They require long-term, lifelong surveillance, and also close follow-up. The progress in this field also, we need to look into the costs which are involved with these endovascular stents. So the role, if you ask me, it is the TEVAR or EVAR. It's a multi-specialty procedure. In fact, they were developed by multiple specialists, primarily vascular surgeons, CT surgeons, and interventional radiologists. So surgeon role, even though the TEVAR develops to next level, the surgeon involvement is always required, especially to create a vascular access, left carotid to left subclavian bypass, or to manage the complications of TEVAR. And the interventional skill, they are required to catheterize the true lumen, especially in acute dissections, which is very difficult, and also treat any vessel with the endograft. And we also require the expertise of radiologists in planning the EVAR. And there is a close involvement of personnel from industry as well. Thank you very much.
Thank you, Dr. Vikram, for the nice information. I only wish more your audience should have benefited from so much of information. Just one question, do you require fluoroscopy in the theatre for this?
For hybrid theatre, you have C-arm.
Oh.
Under the guidance of C-arm, you need. The femoral vessels, the iliac, they should be at least 8 millimeters, minimum 8 millimeters. And the iliac, the external iliac, the common iliac should be more than 15 millimeters for the device to go in. Sometimes the femoral vessels are extensively calcified or tortuous. In those cases, we go through the retroperitoneum and directly put a side graft to the iliac vessel and then put the device.
What is the main reason why open repair is faring better than endovascular repair?
The open repair, so the stenting, especially the present generation of stents, they are subjected to wear and tear, and it can also thrombose. And also the complications like endoleak, the type 1 to type 5 endoleaks. If the proximal landing zone is or distal landing zone is not properly tight, then type 1 endoleaks can happen, and then aneurysm keeps on expanding. Or it's one of the spinal arteries, they can also keep on bleeding between the aorta and the stent, then can lead to stent failure.
Any other comments from?
Yes, arch of aorta. In Liverpool, I've seen, not here, but at least 4 or 5 cases I remember. 4 or 5 cases where they debranch the aorta and then debranch the neck vessels and then stented the aorta. But of late, they were using the EVITA process.
Subintimal hematoma or intramural hematoma, sometimes we detect by transesophageal echo. That is supposed to be a precursor for a dissection.
You treat it as a dissection. If it is an ascending aorta, you treat it as a type A dissection.
So I saw one more speaker, Dr. Aide is here.